Hi, everybody, and welcome. I'm really glad to see you guys here. I hope you're all hungry because I think we have enough pizza out there for everybody to have an entire pizza. So please feel free to partake. There's cookies out there, too. How many of you guys have been to any of our student lectures before? How many of you first time? Okay. Great. So I'm Dr. Laura Lieberman. I'm Director of the Office of Faculty Development at Memorial Sloan Kettering. In addition to doing a lot of programs with faculty, I do a lot of work with students because the students will be our future doctors and scientists and healthcare providers and researchers. And so we really want to engage our students in a learning community of people who are passionate about healthcare and cancer and related issues. So we started this series. We open it to students at all levels as well as to our own staff. And we try to talk about issues related to cancer that would be of interest to our students. And so I'm delighted today to have with us Dr. Abraham Aragones. He is in our Immigrant Health and Cancer Disparities Service, and he's an expert on immigrant health. And he's going to talk to us about health disparities and immigrant populations. I am delighted to present to you Dr. Aragones.
Oh, there you go. Can you hear me now?
All right. So, just so I know, we have high school students. Is that correct? No, no one, no high school student, college students. Yes, the majority of you. Some staff as well. Good. The rest are not. Unknown, uncommitted. The rest. Okay. So I actually have had the chance to give talks to similar groups in the past, and I really have enjoyed them. And one thing that some of you that were here before that heard my talks or were part of my talks know is that I'm probably going to ask you to be part of this conversation, not just sit there and listen to me. And since we're not that many, I'm probably going to point at you and ask you specific questions. So don't hide your faces or don't go. The further you go doesn't mean that you're safe, unless you're really far. But so I really mean it when I say that I want to make this as interactive as possible, a conversation. I learn from these talks as much as, hopefully, as much as you do. So I welcome any questions. You don't have to wait until the end to ask any questions. Just let me know, either raise your hand or just let me know that you have a question. I'm happy to talk to you, to try to answer them. So at any point, just stop me and we'll talk. We're going to talk a little bit about health disparities, the broader topic of health disparities, in particular within within immigrant populations. We're going to basically describe the immigrant populations in the United States, just so we have a little bit better background on who we are. I am an immigrant as well too. Then we'll talk and define health disparities, and we jump into what I think is the most important part of the conversation, which is what are some of the most common causes of these disparities within specifically the immigrant population. Some of these causes, some of these issues that we're going to talk today are not just can be applied to many other populations, many other minority populations in particular. But for now and for this discussion, we're specifically addressing them within the immigrant population. So you don't have to answer this either. But any immigrants in this room? Good, we have a lot. Excellent. Myself too. Many of us actually have parents that are immigrants as well too, so we know a lot about what they have been, their interactions with healthcare. Probably some of them have actually had to go through treatment for different diseases, etc. So I really welcome your experiences and your opinions about the different topics that we're going to be discussing today. The first thing is basically who we are. And this might sound like, well, we know, there are a lot of immigrants in the United States, but I ask this question very often. Why are you concentrating on immigrant populations? Why not just the general minority populations, which is true. I mean, we do. We do a lot of work within, large minority populations with different issues, etc. But why we put this immigrant in our title and why we concentrate on immigrants? Because we're a very large population in the United States. So we're about 325 million in the United States. This is according to the census a couple of months ago. And we are 42 million in this country. 42 million. That's more than almost 80% of the countries of countries in the world, the population of countries in the world. So we're 42 million. 15 million actually migrated before 1990, so a fairly large number of immigrants have been here for a very long time, but a fairly large number has actually migrated very recently, just in the past 5 to 7 years. So we have those that actually have been here for a long time. They know very well the ropes. They understand how to access, or some do. And we actually have those that just got here. We have no idea. They have no idea about the system or have very little experience with the system. Now, it's very unfair for me to put a number of 42 there and just say, well, we're all immigrants, so we're all the same. We're not, correct? There are a lot of differences. Some migrate here for work with a degree to expand and to continue their careers. Some actually cross the border walking and trying to find some sort of like financial or economic improvement. Some actually come here with their parents. Some actually are brought here by their kids or their family members, which is the most common way to migrate. There are many different, some come from Latin America, some from Asia, some from Africa. Different countries, different languages, different backgrounds, et cetera, et cetera. So although I'm putting here one number, 42 million, we do come from all over the world. We have actually a very large representation of almost everywhere. And one of the things that I like to tell about my students, or when I talk about immigrants, is that not until I moved to the United States that I actually interacted with people from some countries in South America. And not from the typical ones, not from Chile. I'm from Peru, by the way, and that's the reason why I said that. Not from Chile, Ecuador, or Colombia, or Argentina, the ones that you guys know. But people from Guyana, for example. I never interacted with someone from Guyana. Actually, I never heard of Guyana. I knew that it was there, right on the north of South America. It's somewhere there. It used to belong to someone else. Now, all these things, I know that. But I never interacted with anyone from that country. I never heard a news from anyone from this country. All of a sudden, I had 6 students. The first year that I was teaching a class, 6 students from Guyana. We have, over 90,000 Guyanese just in New York City? That's how fascinating our population is. And you can imagine the differences that exist within our population. So, are Guyanese from South America? Yes. Are they Latinos? No, really? I don't know.
Well, yeah, they're Latin American, yeah. They're not Hispanic.
They're not Hispanic. Are they Latinos or not? Are they Caribbeans? They don't speak Spanish. So, complicated.
Yeah.
That's my point. My point is not to try to define any group today or to try to actually make a point about specific populations, but it's very complicated. When some people talk about Africa, it sounds sometimes like they're talking about one country, really. There are over 50, I believe, or so, with different languages, different backgrounds, different cultures, different parts of it. They're so different. So again, 42 million people, it's an enormous amount of people. It's a significant number, but don't forget, please, that there are many, many differences within this population. And what I'm going to try to do today is sort of like address the issues that are common to all immigrants, reasons why they can't access care, or they have, or we see some of the disparities. Again, please stop me if you have any questions at any point. This is something that I know I presented last time, but I really think it's very interesting. And this number apparently is lower. Back in 1990, every 16 seconds, there was one more net immigrant in the United States. So literally every 16 seconds, you can say that there's, one more immigrant in the United States. Net, between those, those that come here minus those that actually leave. A lot of immigrants go back to their countries, etc. There used to be 1+ every 16 seconds. In the 2000s, particularly after 2001, this went down every 22 seconds, and now we're actually down to 29 seconds. It's a lot still. Every 29 seconds there's another immigrant moving to the United States, or actually overall staying in the United States. So it's a fairly important population. Not just that we're 42, but we're increasing in number. Okay? This has changed for some populations. For example, there's some thought out there that immigrants from Mexico are still the fastest growing immigrant population in the United States. And it's not, actually. Net migration in some months and some years in the past couple of years has been negative for immigrants from Mexico. So net migration from Africa, some countries in Africa have been positive. So this changes as well too. And sometimes it comes from, you can look at the 70s with the large populations coming from Asia, then the 80s, large population coming from from Eastern Europe and ex-Soviet Union, et cetera, et cetera, et cetera. So it changes depending on the decade, depending on the issues that are occurring in the world, et cetera. And as you know, there's a lot of discussion about this and immigration in general in the news these days. I'm happy to answer any questions and give you my opinion. And of course, these things have consequences in access and care, and we're going to talk a little bit about that in the near future. I would love to hear your opinions as well. So that's the population. Okay, we're talking about 42 million. I don't want to jump into too many details. If you want to know more about each of the populations, I'm happy to answer questions. But just know that we're 42 million plus. We're still growing in number, and we'll continue to grow in number. And that number is increasing fairly fast. Fairly fast. Not as fast as back in 1990, but fairly fast, and we're very different populations. Well, what are disparities? Really, we talk about disparities all the time. We're just defining these two concepts. Who are the immigrants in this country? What are disparities? We talk about disparities all the time. All the time. This is actually a whole area of research and public health. I mean, health disparities and healthcare disparities is huge. We do a lot of work in this. Most of my work, if not all my work, is in this area. And it can be defined actually in these 3 lines, no more than that. You can make a much larger definitions, but differences in the overall rate of diseases, incidence of the disease, prevalence of specific disease, morbidity, mortality, survival rates, or burden. And the first part, I think, is very clear, really. If we see that there are more, for example, Guyanese populations with rates of thyroid cancer than the general population, well, there is a disparity there. There shouldn't be. Why? Really, maybe there should because of some reasons, but overall, if we cut those issues out, or we treat those issues, then it should be the same as the general population. And so incidence, prevalence, those are actually morbidity, mortality, survival rates. Those are easy to understand, or easier to understand. And we get this information very often in the news and tons of articles. You know, there's more diabetes, or immigrants move to the United States. That recently moved to the United States. They have a very low rate of obesity. But after they stay here for about 4 years or so, the obesity rate within the immigrant population increases to the same level of the general population. So we understand that, that's sort of like the opposite of a disparity. Immigrants were better off, and then after 4 years, they actually get as bad as. But those are changes that you can distinguish. You can understand those numbers. What is a little bit more difficult to understand is the healthcare disparity part. So that maybe right now you might not find a connection to a specific disease or a specific issue. But if I tell you that immigrants are less likely to have insurance, you don't have to believe me. You can just go online or search any database, and you can find that if you have access to insurance, your outcomes, your health outcomes are much better than those that actually don't have. So that's one way to actually talk about disparities. If you have access to transportation to go to the doctor, and if you don't have access to transportation to go to the doctor, your outcomes probably will be worse. And you can then go back to the burden of that disease, the burden, for example, of diabetes, a very easy one to understand. If I don't go to the doctor, if I don't actually go to the eye doctor, and if I don't go to the neurologist, or all the other specialties that you should be going to treat my feet, etc., if I don't go to them and get actually the care that I need, and get the prevention that I need, my outcomes, specifically in diabetes for that particular population, will probably be worse off, and we know that that's the case. It could be because they don't have the population doesn't have access to the transportation. Again, this can happen in the entire population. Once again, we're just focusing on the immigrant population, but this can happen in the entire population. If you don't have access to childcare, then you might not be able to actually go to your doctor. If you don't have money to pay for food, and you have to choose between food or going to care, and yes, that happens extremely often in this country, then your outcomes might be worse, and you might end up having a disparity. And again, the disparity is just basically a comparison of any of this between the general population or one population versus the other. Most of the time we talk about, for example, as I said before, the rate of obesity in the general United States is 24% or something like that. I could be wrong, but I think it's about 24%. And within specific population, it's 35%. Well, all else equal, that difference shouldn't exist. So what are the causes of that difference? Make sense? Yes? Yes? Yeah, that's a very good question. And we're definitely going to talk a little bit about the legal aspect of it. Yes, most of the time when we talk about numbers of immigrants in the United States, we include all. For health purposes, I believe that's how it should be. But yes, they include. We include about, depending on who you listen and where you read or what information you read, somewhere between 9 and 11 million undocumented immigrants. About half of them are children or below the age of 21 at least. So yes, we usually include documented and undocumented. Of course, undocumented immigrants, and we'll talk about that, have even bigger issues. And if you look at specifics within that population for some of the disparities that we're going to discuss today, they're even worse, actually. And we're going to talk about why, and hopefully at the end of this conversation, it will make more sense. But yes, we always include undocumented immigrants in the numbers. Sometimes, some publications might not, or some data sources, but as far as the data from the government, almost always include undocumented immigrants. Okay? Any other questions so far? So this is actually the Health and Human Services last year. This was in one of their publications last year. I don't have anything from this year. I wonder why. But they actually said specifically that disparities still exist. Not just it still exists. They're actually, some of them are not getting better, and some are actually getting worse. And this is for minority and immigrant populations in general. So this is not a story of your grandparents or something that used to happen back in 1992 or whatever it was. This still happens, and it's actually, for some cases, getting much worse. And I have examples of this, because I want you to actually sort of like see what we're discussing about. So this is not specifically about immigrants. Not at all. Okay, this is just the general population, but I think it's a really cool way to see what a disparity is. This is life expectancy. This was from back in 2012, and for all purposes, it's the same as it is right now. I'll point some of the differences. But the life expectancy in the United States is 78 years. A simple way to think about it, if you're born today, on average, you are very likely to live all the way to 78 years of age, 78.6 or something like that. In no way close to most of the other Western countries. But anyway, we're still up there, 78 years of age. But if you look within specific populations, you can see that it's not the same. If you're actually a black male in the United States, your life expectancy is almost 6 years less. It's unbelievable. It really, if you're a black person in the United States and you're born today, you're most likely going to live 6 years less than your counterpart white male. It's enormous. So why is this important? Well, first of all, it's important for those of us that are actually very interested in health. The person is dying. Why is it dying? Is it accidents? Is it gun violence? Is it actually not accessing care? Is it actually some other issue out there? And that's actually where it gets very interesting. But it's also interesting for policy. If you're interested in politics and policy, you might have heard that people are talking about lowering the age of retirement. Increasing the age of retirement because people are living longer. Well, who's living longer? Yes, in general, most of us are living longer, but who's the one that are actually living really longer? It's actually white females, but in general, it's actually whites. Yes, our life expectancy has increased, but it's not the same for all of us. So don't lump all the populations into the same group. What we're not showing here is that since 2012, the life expectancy for white men has decreased, has actually gone down a little bit, and for a particular population of middle-aged white men has actually decreased tremendously. And we can talk about that later, but it's fairly interesting, and there's a lot of data on that these days. But black, male, Hispanic, etc. in general, it's lower. Females usually higher. Not the same for everyone. So this, I think, it's a good example for disparities. Really, this shouldn't happen if all else is equal. So we can actually talk about more specific. This is data from New York. All I want you to see here is diabetes. If you're U.S. born, your rate of diabetes is lower than if you're actually born in the United States, born abroad. That's in New York City. Now, yes, you can see this, the right side. Really, immigrants that actually have lower rates of hypertension, lower rates of obesity, lower rates of depression in general. We can discuss that in a minute. And as I said at the beginning, there are some disparities that are actually for immigrants. Did I say Latinos? If I did, I'm sorry. I mean immigrants in general. But there are some disparities that are against against the U.S. born, but in general, the ones that we looked at, and there's some ways to explain that, but in general, what we're looking at is actually, for example, the case of diabetes, where that is a significant higher rate of diabetes in the general population. Within this in New York City, we know that, for example, immigrants from Mexico have one of the highest rates, almost 3 to 7 times higher than the general population. Why is that? Again, we'll talk a little bit about that in the future. Any questions so far about this one? So I have a couple of other examples that I want to make sure that you see, and this is one that I think is very important for the work that we do. This is in New York City. Data from New York City from 2014, leading causes of premature death. So if you die actually before the age of 65, okay, what are the most common causes? Well, the top one is actually cancer, as you see there, but look at the difference between U.S.-born versus foreign-born. That is a significant difference. And to me, at least, it's really interesting to dig into to see why is this happening. Is this happening specifically in one population? Is it happening in the general population of immigrants? What is the cause of this? And again, hopefully we'll talk and we'll have answers in the next few slides. Okay, really, really important. This is actually the reason why I guess I work here and I have a job. I wish it doesn't exist, actually, but it's still very, very prevalent. And I have some slides showing this issue as well in the next ones. So again, this is only in New York City. This is data from the whole country. And all I want you to concentrate is right here. This is actually for mammograms. Mammograms is to detect breast cancer, early detection of breast cancer, hopefully. I'm not going to discuss the different guidelines and some of the confusion that is out there. In general, every 2 years, 40 or older. What I want you to see is actually right here, born in the United States, about 65% of women report having a mammogram every 2 years. And if you go down the list and you look at those immigrants that actually moved to the United States more than 10 years ago, it's already lower. And if immigrants that move to the United States less than 10 years ago, it's 46%. So you can see that difference, and you can start to think about some of these differences, really. If I don't actually prevent, if I don't early detect some of these cancers, my chances of not having an adequate treatment and not getting cured, et cetera, surviving are much higher. So this is a mammogram or breast cancer. I also have an example of cervical cancer. This is one of those that actually we do the best in terms of screening for or prevention. And you can see that all in all, it's actually 81%. Born in the United States, 83%. Born in U.S. territory, 74%. I hate that we make that distinction, but it's there. And now more than ever, we know that there's a big distinction, really, sadly. But look, if you're actually in the United States less than 10 years, 68%. And this is even more important. You don't need to know this, but it's even more important because most of cervical cancer cases in the United States occur within the immigrant population, Latinas and women from Latin America and women from Africa. Most of the cases happen there. So, and we're screening a lot less than what we should, than the other populations, and a lot less than what we should. So again, you start thinking about some of the reasons for this. Really, should someone die from cervical cancer these days? Very few, if any. So why are so many women, actually around 4,000 or so, dying from, most of them Latinas and immigrants from Africa? Well, here it is, and here is some of the answer to that. And I have one more of colorectal cancer. We do this to prevent cancer in the colon, the rectum, through, just look at the endoscopy part. It's basically a colonoscopy. You look through the camera into the colon. We don't do a great job in the United States. About 60% of the population that should be screened or for colorectal cancer get a colonoscopy on every 10 years, whatever the guidelines is. But if you look down here, look at this number. I mean, it's 25. It's almost non-existent, really. And if you look at the FIT or the stool test, there's just no data whatsoever. It's just very, very low. In any case, another explanation for what we were seeing before, we don't prevent within the immigrant population, so we don't do as well as we do the general population. And you can argue that in the general population, we don't do a good job either. But even worse, we're doing a pretty good job, pretty bad job within the immigrant populations, in particular within those that recently moved. So my question to you, before we jump into the barriers to care, is like, well, why would there be this difference? Why within those that migrated less than 10 years versus those that migrated more than 10 years? Why is there that disparity? That is the disparity within immigrants, correct? The burden of this, or actually the use or utilization of cancer prevention or cancer screening is different within those two populations. Why is that the case? Any thoughts? Yes, I'll go to you guys. Yes. All right, so education, is there any reason for you to think that one population is more educated than other? Like, do you think that those that migrated long ago are more educated or less educated?
Maybe it's not that they don't have enough resources, but they don't know where to go to get these things.
Okay, so resources to access different, I'll get back to you. Yes?
I was going to say language barrier.
Yes, really, one of the most common ones, that's the easiest one. So you literally touch the land of the United States and all of a sudden you need English to be able to access different things. You're going to have an awesome lecture about language in a month by Dr. Diamond, and I really recommend, we're going to touch a little bit on language in a second, but I really recommend that you come back Tuesday, November 28th. There's so much going on in that area. It's unbelievable. And a lot of work done here at Sloan, so I really recommend. Someone, yes?
I think it's fear and mostly emphasized by the media.
Yeah. So legal issues, really, and not just fear. I would say legal issues from the perspective of the law, of the policies that actually we have in place right now. We're going to discuss that in a second, but there is a big difference if you've been here for 2 months and you're undocumented versus if you've been here for 20 years and you're undocumented. Sadly, both are actually very, have a lot of issues against them, but you might feel more comfortable about your surroundings, where you live, more established, more support, etc. But yes, absolutely, and you can assume that the longer you're here, the more your chances that you actually have become documented or legal, and you can assume that's the case, especially for those that migrated before 86 or 87. I'll get back to you. Yes. The cost. Why would the cost be different between the recent migrants versus older migrants? I agree with you, but I wonder why. I'm sorry? Okay. Your point is absolutely correct. Go back to my question of why the difference between the two populations and the cost. Why one, and cost is a general concept, not just as a unique, out of pocket or whatever you can think of. So one population has been here in the United States less than 10 years, is having all these disparities. One population has been here more than 10 years, is not as bad as that, so it's doing better. Why is the difference there? Because of cost. Why would you point at that? It's, well, maybe that's the reason within cost. I didn't hear you.
Can I think about it?
Okay, yeah, totally. Take your time. We have until 6 or so. Yes. Yeah.
Touch on that. So those who've been here understand the cost associated with healthcare, whereas those who just arrived, maybe in their previous country, they have more comprehensive, like a single payer system.
Yeah.
The copay is zero, effectively like $5, whereas here copay could be $30.
Yeah, so that definitely can explain some of the difference, and that, I mean, I don't have a particular data to support that, but it sounds like a reasonable conclusion. I have another one actually that I'm looking for. And wait, you wanted to say something, and I'll go back in the back. Yes, this is the area of talking. I mean, you guys want to move here, or I'm kidding. You can stay there. Yes.
I just wanted to expand on what I said. The fear. I work in a hospital and I see people fear to come into the emergency room because they think, well, this is more for undocumented people.
Yep.
They fear they're just going to put doctors are just going to put them in an airplane. To go
Yes.
back to their country.
Yeah, so maybe they're actually less likely to show their face, to show when they need care, etc. Absolutely, we're going to talk a lot about that, and that's absolutely a very good point. So the fear of being part of the system, getting into the system, in particular within the undocumented immigrant, that's definitely one issue. Let's go back to the costs before we jump into the next slides. I'm sorry, all the way in the back. Yes?
A big thing would be like knowledge of clinics.
Okay, yes, accessing, navigating the system. The more time you're here, the more you kind of like know that there's so many systems and every state is different, etc. and how complicated it is? Absolutely. Yeah, the more comfortable you feel in a place and your surroundings, the more you might actually be able to use the services. I'm looking for something a little bit different. Yes?
For immigrants that have been here longer than 2 years, their financial standing might just overall be different. So, like, taking a day off from work for them
Oh, huh.
one of the consequences of having access to transportation.
Yeah, I haven't thought about that. That sounds, again, like before, a very plausible conclusion. Again, I'm not thinking necessarily about that one. I think there's one more that it's a little more, but I'm going to go to the other side. I'm sorry. Someone wants to talk from here. So, yes, I'm sorry I pointed at you, but...
Continuing on our cost side of things, it's also expensive to come here.
Okay.
As far as paperwork and visas, if
Yes.
you choose to go that route,
Yeah.
you may be more established after 10 years.
Yeah.
You found a better job.
Huh.
Things that
Okay.
as immediate, you may not have to.
Okay. Yeah, I'm actually we're thinking about something different from what you were saying at the beginning. So, have you heard of this idea that immigrants are usually more are healthier? I'm sorry, than the general population. Have you heard of this thought of like, well, immigrants have better health and they're usually healthier than the counterparts? This is a very well known like issue that is discussed there. The point that you're making is actually very interesting for that purpose, and one that I was actually before saying like, well, don't look too much about this right side. The migration to a country is a filter. Not everyone can actually migrate to the United States, and if you take the whole population of immigrants as as one group and put them together, those that migrate usually are much healthier than the general population in their country of origin, or much better off. So you were saying it costs a lot of money to move, regardless of how you come. If you come in a plane, or if you come in by land, or you just walking through the desert, it costs a lot of money. You have to be healthy for that purpose, not just to migrate through these methods that I just mentioned, but you have to go actually through a medical test to migrate to the United States or to get the citizenship or residency, etc. So all these are filters that actually make you get in an otherwise very healthy population. So if you look today, well, yeah, they might actually be doing, they're much better. And as a whole, all these issues are skewed to better than the general population. But if you stay here longer and you're eating enough of the food that we eat and dealing with enough of the stuff that we do and the system that we have, then you sometimes, in many cases, you're worse off. So that's what I was thinking about your point. But I'm going to say it because I know we're running out of time, but it's insurance. And I think it touches on some of the things that you guys were talking about. So if you come to this country and you're here today, this is your first day. Even if you're a legal person, you have your green card, but this is your first day of as a resident of the United States, you're under a completely different picture, legal picture, than someone that has been here for more than 5 years. And that's based on a 1996 law. It is. So the longer you're here, the more access you have even to insurance, including ACA, by the way. So not just Medicaid and tons of other things. So the longer you're here, the longer you're a resident in the United States, the longer you have been in the United States, the longer you actually have access to federally funded, federally funded programs, not just health, but in general other things. You had something to say? I'm sorry. Yes?
So I know with that it's usually 5 years.
Yeah.
And it's
Of legal residency.
and children, but does that also apply to like people who are getting insurance through their workplace?
So we're going no, that's private insurance. Most of the time that doesn't apply. It's just any program. A very simple way to think about it is any program that is funded by the government, in part or in general. But the states have a lot to say, and we're going to talk a little bit about that. So anyway, think about it that way too. Insurance is key to access. It's not everything, not at all, but it's a big part of accessing care, and one of the main reasons why you see this big difference between the groups. Everything else that you said is very plausible, and I like what you guys said. It's things that I have not necessarily thought about. So this is what we discussed. These are other issues that are much more, I couldn't put it in a table apparently, but they're very common in the general population, in the immigrant general population. In general, immigrants are less likely to receive routine preventive services, so going to a doctor just for a general checkup, they're less likely to do that, less likely to have insurance, less likely to actually have a regular source of care, a place where if they need care, they end up going to either someone that they have not seen before or the emergency room, as that was discussed here. And what is very important to me, and it's something that is very interesting for the area, my work, is they're more likely to report that they actually went, at least in the past year, they went without they had a problem, they had a medical problem, and they went without actually seeking care, the necessary care. And I think that says a lot. If you did not actually feel comfortable, for whatever of the reasons that we're going to discuss in a minute, to access the system and getting the care that you needed, then your outcome most likely will be worse off than the general population. And what are the long-term consequences of that? Well, you can imagine. If your problem last year, in the past year, was that you needed to access insulin or any other treatment for diabetes, well, the long-term consequences of not treating diabetes are very clear, really. You might end up without food, with tons of other heart problems, kidney problems, et cetera, et cetera, et cetera. So sometimes it's hard to think about those long-term consequences as you're looking at one thing right now, but try to think about it that way. Whatever happened last year, even if the person is actually better right now, or it's actually perfectly fine, no more problems, what are the long-term consequences of that? Did they actually go to their chemotherapy? Did they actually, in the past year, they needed treatment, they actually needed to get their radiation or the chemotherapy, but they decided not to go for whatever reason. And there are multiple of those, and happens often as well, too. So think about those consequences. So what is causing these issues? What are, in particular within the immigrant populations, what is causing some of these things, some of the differences that we can see now? I'm going to talk, before I jump into some of the specifics of the accessing care through insurance and cost, language and cultural beliefs, I just want to talk a little bit about the safety net. And what is the safety net, and why do we actually care so much about the safety net? This is a definition of the IOM for what a safety net is. The reason why I'm bringing it up here, I'm sure you have heard of this idea before. I want to just show you how broad it is. It's not just the safety net in New York City. It's not just the 11 large public health hospitals, which are great and do really good work, but it includes providers in every neighborhood that speak different languages, federally qualified health centers, community vaccination, immunization clinics, everything that you can imagine. The larger it is, the more the net, the more the web, the less people go through, and the better the outcomes are. That's the way to think about it. The best safety net out there, the better the safety net out there, the better the outcomes of your population. In particular, those populations that need that safety net, which are in general populations of low socioeconomic status, don't speak English, or have limited English proficiency, have cultural issues, and tons of other reasons to reduce their outcomes. It's very broad. Just think about the safety net as a very broad issue. A well-developed safety net, as I was saying before, may include a very relative, extensive number of hospitals, clinics. We have tons of those actually here in New York City, including providers. And what is really important for the safety net is the legal environment, really. If the government, the federal government, or the city government, or the state government, it's supportive of this net, and there's actually resources, etc., your net is much better. Your net is actually thicker and less people go through. And a way to actually think about this is I have a few examples to think about the safety net, how can it actually change based on the legal issues. So I don't know if you know the Children's Health Insurance Program, which is actually an extension of Medicaid. It covers children under a certain age, and depending on the parent's income. It was really good. It started in the 90s. It was really, really good program. It covered millions of kids, and it improved the outcomes of millions of kids. Almost every single state took over. One of the first things that Obama did after he took over his first term is he expanded the Children's Health Insurance Program to include more kids, basically by increasing the outcome, the salary of their parents. So the higher their salary, their kids are still eligible for a Children's Health Insurance Program. And not all states actually took that. And by last week, actually, this was, it's over. Exactly, this extension sadly is over. I think we're going to repeat this very often in the next 20 minutes. But this is actually over. But it made it for a really interesting natural experiment, as natural as it is. I mean, what is the outcome of children in those states versus those other states that actually didn't take this expansion? One way or the other, most states end up taking some of this expansion, but those that took the full advantage of this, their children are doing much better in vaccination, much better in less days actually missing school, etc., etc., etc. This is clearly a win-win situation. Clearly, there's no actually two ways about it. But look how important it is. This was the legal framework. Some actually of these states, was up to the states to decide. Some states decided to take it over and improve their safety net by increasing access to the safety net. That's part of the safety net. Actually, insurance itself is part of the safety net. And the outcomes were much better. And this really, especially in New York, including today, even if I was saying that last week some of this has ended, in New York, New Jersey, Connecticut, etc., this program covers so many immigrants. I can't explain you how many. I work specifically in HPV. That sounds like the president, actually. I can't explain you how many. Believe me, it is actually a lot of people. It covers so many kids, including undocumented children as well, too. This is the number one access to for care for the majority of undocumented children and a very large number of documented immigrants. This is a program that has saved so many kids and have improved their lives so many ways that it's really sad to see it reduced. But anyway, we'll see what happens in the near future. So that's just an example of how the safety net plays a role and how so many variables are out there. Well, even to access the safety net, by that I include the hospitals and providers, etc., there are barriers. There's still issues to access that safety net. And we're going to talk about a few of them. Not all. These are not all of them. Just what I think is some of the most important ones. Cost and insurance is one of them. You guys mentioned cost and insurance. This is not all. Okay, people in other countries, including in particular immigrants in other countries, even in developed countries, do still suffer from disparities, even though they have a universal healthcare access, blah, 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 blah. So this is not the panacea. Having access to, having insurance or giving insurance to everyone is not the panacea. It is definitely the first step. And without the first step, you can't take the second and the third and the fourth, etc. But it's not the only one. So whoever works in this area, after this, you will still have a job. Because sadly, the population will still be suffering from other issues and will still be actually not able to access care for other purposes. But let's talk a little bit about cost, since it's that first step. Well, insurance in general. I just told you about Children's Health Insurance Program and the expansion of it and how it covers actually even undocumented children and how the children have access to free vaccines, free treatment, free annual care, et cetera, and how much it has improved the outcomes of that population. Well, ACA has done sort of like similar thing for documented immigrants and immigrants that have been here more than 5 years. Not for everyone, but those that have been here more than 5 years. Have an expansion of Medicaid, which is what many states, not all, but many states took, and it's something that is actually in discussion about, taking, reverting or giving as a block grants, etc. That expansion of Medicaid has expanded the coverage of many immigrants, documented immigrants. And we're going to talk a little bit about cost, transportation, and childcare and food in a second, but before that, I just wanted to talk a little bit about ACA, and Laura and I were discussing on maybe having a larger presentation about this. This is in no way trying to touch in every single aspect of ACA and how it changes every minute. Just last night, we were talking with an audience, and a community-based audience, and we were talking about ACA, and many were saying, well, is this really relevant anymore? I mean, well, maybe now it is. Yesterday it felt like not, but we still have it. In any case, based on the law, based on what it's written, are immigrants eligible? Those that have been here more than 5 years, yes. They can definitely go through the exchange and get insurance or even get Medicaid expansion. Those that have been here less than 5 years, most probably not, although different states have different undocumented immigrants. No way. No, it's written in the law. No undocumented immigrants in the exchange or the expansion of Medicaid. Yes?
So when we say documented immigrants, we say longer than 5 years. Does that include also the immigrants that already have their citizenship and are documented, they still would have?
That's a very good question, and I'm sorry you didn't define some of those terms. Actually, I would say that all immigrants that are citizens have been here in the United States, or have been residents at least of the United States for over 3 to 5 years. So they're not under some of those restrictions. The population that is under those restrictions is most of the time those that actually carry a green card. So that sort of like answers the question, but it's that 5 years still there, but it's only for those that are residents. Now, if are immigrants, one thing that I want to make sure is that everyone understands that if you're a student and you have a visa as a student, you're not a resident of this country. You're not a permanent resident of this country. You're not an immigrant. Okay, you're in transition. I mean, you're supposed to go back and your status will end. You're a transition. You're not considered a permanent resident. Once you get a green card, then you're a permanent resident. You're actually taking, those 5 years, etc. It didn't used to be this way before 1996, and some of the welfare changes that happened in 1996. It used to be completely different. Every immigrant was the same as any other population. They had access to every single program from day one of immigration, and many undocumented immigrants had access to these things. But for political reasons, this was changed in 1996, and it changed the game completely when it comes to immigrant populations and the health of immigrant populations and access to care. Going back to ACA, Affordable Care Act, undocumented immigrants are not eligible. Some states try to push it, and New York City is trying to push something like that, or California, etc. But it's not. One of the things that is really important about ACA, and that is so important for the purpose of disparities, that it's set, not just that it increases the coverage and everything that most people understand, more people can get actually insurance, and actually 30 million more people got insurance, and at least in my book, that's a very positive thing. But it also raises standards, meaning that you cannot, again, one of the things that just recently changed, or might change, but you cannot get what is called a garbage insurance, one that is actually, you're insured, you can say and get your paper and tell the IRS, whoever else, I have insurance, and all of a sudden something happened. Literally, you break your pinky and you're in Chapter 11 or whatever it is. I mean, you're bankrupt. Because of the standards of ACA, you cannot get that. So the minimum standards are set, but it includes also a lot of prevention. So, for example, regardless of what program you take from ACA, it will include a free preventive visit to the doctor, so a general checkup, and you will not have to pay out of pocket anything. It will include most, if not all, of the standard prevention treatments, preventive care that we provide. So colorectal cancer, mammography, cervical cancer, pap smear, et cetera, all that is covered. So imagine how much easier it is for someone that has ACA insurance to access these services. There's no out-of-pocket of that. So if you cut that, and that is about to happen, then you're actually not just letting people say once again, well, I have insurance, I don't have to pay a penalty, or more people, or we can fake it and say that, well, more people have insurance in this country, but if you dig deep, that insurance is garbage, and that insurance will not cover any of the things that I'm telling you about, and at the end of the day will not in any way, shape, or form reduce the disparities. And by the way, I hope you're not this young, but we know what happened in the 2000s with this. We had 55 million uninsured. The outcomes were worse off. I mean, this is not a new game, or we don't know what's going to happen when those 30 million people are going to lose insurance. We know very well. We have the 2000s to practice. 55 million people were uninsured as compared to about 29 or so now. Still an enormous number, but we know what happened. So minimum standards is very key of ACA. To reduce disparities is something very, very important. In terms of Medicaid, emergency Medicaid, again, this is not a lecture to define these issues. In no way, I'm sure you can spend semesters learning about this. But in terms of cancer treatment, I wanted to point out something. In New York, and this is not for every state, it's actually a very minority of states. In New York, if you have emergency Medicaid, you can get cancer treatment through emergency Medicaid, which is a way of how many undocumented, not most, but many undocumented immigrants get cancer treatment through emergency Medicaid. This is in no way the same in Pennsylvania or the same in Alabama or tons of other states. The majority of states don't have that. So think about this safety net and how the outcomes actually play a role based on some of the insurance and programs that we have and how we actually structure them, etc. This is a huge thing. And this is, from the past 10 years, 12 years or so, where you live, where your home is, and that, your ID or whatever matters in this country when it comes to cancer treatment, for example. It's just ridiculous in my mind. But anyway, this is how it is. And think about it when it comes to outcomes, cancer outcomes. When it comes to cost, and this is the other part, so one area is access to care in terms of the insurance, paying out, having to pay for all these treatments and how, etc. But what about cost? There's a lot of the general issue of cost. There's a lot of actual confusion about eligibility. Not everyone is eligible to Medicaid or ACA, as I was telling you. Not everyone wants to put their name. There was a lot of conversation here about not wanting to show your ID or tell who you are to the hospital or the insurance company because you become a public charge. So if they discover that you're actually an undocumented immigrant, this is something that happens almost every day in our work. People fearing that if they discover that you're an undocumented immigrant, your children will actually get charged by the government, etc. So why would I put my name there? They can come and deport me as well. Having to sign something like, for example, the insurance, saying that you are actually a legal immigrant, language issues that you're going to discuss next time, fear of reporting immigration status, and this has become more and more of an issue these days with all the talk about immigration. These are some of the reasons why even if the program is there, if Medicaid is there, and I encourage you to visit some of the clinics around the public hospitals. Most of the time there is a table with Medicaid and people that give you information and they can help you actually enroll there. I encourage you to look at that information and how actually terrifying might look if you actually are on the shoes of someone that is undocumented and has all these other issues, kids, etc. here. It is not as straightforward. Okay, great, the program is there. I might be eligible. Let's say I'm documented. It's not as straightforward as just going there, signing, and getting your card. It's very difficult. Yes.
It's not as straightforward for someone to be a citizen.
Correct. Oh, yes. Yeah. Yeah. 100% agree. It's almost impossible sometimes, and the loops that you have to go through and the circles, and it's almost like it's set up that way so you can't use it. And again, another thing that is different within states and within cities, just think about the language. If the forms are not in your language, but if you cross the river and they're actually in your language, I mean, why? And why are you like accessing here and not anyway? It's very, very difficult. Yeah, so one of the things that sometimes you actually have to sign some paperwork where it says that, someone that is actually, you're going to be covered for this person if that person is not eligible for whatever you're applying at that moment. That's one area. But also many immigrants that move to the United States as part of which is the most common way to migrate to the United States, which is a family member bringing you here. Most family members actually sponsor you in a way. Basically what it does is, and again, this is based on 1996 law, your family member takes care of you for the first 5 years. And they have to prove they're going to be able to do that. So if you end up actually signing something and you're not eligible and all of a sudden you're incurring some hundreds of thousands of dollars cost, it might end up in your sibling or your parents' table, and they might need to actually pay for it. So there's a lot of difficulties in that sense. And it might sound that it might sound complicated right now as we're talking, but I can assure you that most immigrants that have had experience with the healthcare system know very well these details, and they're very aware of these details. And again, fear of deportation, I know that I said this before, but it's becoming a bigger issue. I just wanted to touch on one quick thing about this. Transportation is a cost. And it's definitely a barrier. If you don't have a way to get yourself to the chemotherapy place or wherever else, you will not get the cost. And this is something that is extremely common. It sounds so small and so ridiculous in this, and even in a place like New York City, but it's still an issue. We do have access a ride, and there are ways to actually access. But if you have no idea, how do you do that? You might have heard of navigation programs and people that actually navigate patients and populations through the system to get these programs. Childcare, if you don't have any place to leave your kids. Food, as I said before, and we do a lot of work in this area. If you have to pay for food instead of your treatment, you're probably going to choose food, especially if it's for your children, etc. So these are decisions that are made by Americans or immigrants in this country every day, and they do affect the outcomes of these populations. I'm not going to touch on language. I think it's obvious that it's a big issue. If you can actually speak the language, you will not be able to access the information, and access information is accessing care. Dr. Diamond, Lisa Diamond, is going to speak about this very, very in depth, and I think I'm going to leave it because we're running out of time, but it's very, very interesting. One thing that I will just point out, because I think it's really important as a Spanish-speaking person, We assume that if you move to the United States, you're an immigrant from Latin America, that you speak Spanish. And assumptions are most of the time wrong. Many of our immigrants from Latin America, even from countries that speak Spanish, for example, and I'm telling you all from my experience, and that's why I'm saying Latin America or Spanish, many of them actually speak a different language. Quechua, some other language from Mexico. And so you're speaking to them, it's like, oh, I know he's from Latin America, he's from Mexico, I'm going to speak to him in Spanish. I learned Spanish when I was, I did 6 months in Spain, whatever. I can definitely use that for my care. And you start talking to that participant, and you don't understand that Spanish is their second language too. And whatever information you're passing to that person, it's going to be translating to something different. And you don't know what the level of Spanish that person might have, etc. So it's important to actually dig into these issues, not assume. So I'll leave this for now, but yes, don't use your little Spanish that you learn or your little like Russian that you learn in some exchange semester, because it might not be enough, especially for care. It's not enough for care. This is something that I'm very interested in, but again, I'm rushing through it. Many health beliefs and behaviors are culturally based, and where our populations are coming from are very different culturally than where we are right now. What causes illness? We think that this is, we understand this. Of course, there's a gene there, then we smoke, or we actually, we had unprotected sex, whatever it is that you can imagine. We think about these things and we make, this is obvious. Well, it's not necessarily obvious for other populations. Some might think that actually they made a mistake in their lives. Some might think that it's based on religion. And these are important issues for the care. Why? Because based on those beliefs, they might decide actually to receive care. So if you think that cancer is something that, for example, God gave you, and this is something very common, and that, you just sadly won that lottery and you're going to have to accept it and die, then your work to convince that person that perhaps there is a treatment, that they should follow the treatment, it's going to be a lot more difficult. A lot more difficult. Imagine now prevention. No, it's not. You don't have to get the cancer. I can prevent it. Well, no, if it is actually in my culture, etc., it's very difficult. Trust. Do I trust the system? Do I trust to give my information? But also, do I trust what you tell me? Well, you're giving me this chemotherapy that is making me sick. How can I trust you? It's actually, well, there's a lot of explanation behind. There's a lot of actually cultural understanding of this. And traditional healing methods. Just yesterday, again, I had a question about some treatment with nuts, etc., while you get receiving chemotherapy. If the treatment doesn't actually interfere with if that actually belief or that traditional healing methods don't actually interfere with the care that you're receiving, great. But talk to your doctor. And one of the things that we know is that some traditional healing, especially those that actually use some concoctions or etc., they can actually interfere with the effectiveness of for example, chemotherapy agents. So it's important to talk to your doctor, but at the same time, it's important to encourage them to do what is best for that person to actually have quality as well too, and perhaps even increasing their chances of curing. So understanding these issues and having some competency in some of these issues, and understanding that they can be barriers to access care or to the or can actually create some disparities is very, very important. Some of the issues that actually are very common is that how we communicate health, our health problems. So it is actually mediated by culture and traditions. You probably have seen someone that just actually smashed their toe and yells and probably goes to the emergency room. Nothing happened, but it's like, oh my God, this is the worst that can happen. And the person next to that one is, the same thing happened, might not even say ouch. You can argue that their pain level is different, and probably there is some of that too, but the reaction to that pain can be different as well. This is a very simple example, of course, but now think about it. Well, what is your reaction to cancer? Do I take it as like, that's it, it's over, it's done? Do I take AIDS, HIV as that's it, it's over, it's done? Or do I actually communicate that information in a way that it's, and not just to me, but to others as well too, in a way that is positive, or there's a treatment, etc. How we present our symptoms, as I said to you before, what the pain level is actually, there's a lot of literature on, for example, how different cultures take the similar pain level of or similar issues of stones in the gallbladder, how they actually represent that pain, and depending on the pain charge, etc. And there's I don't want to give you the wrong information, but I believe it's from some Asian countries, the scale of pain is much lower than those actually in Western countries, and it's just different. And for all other purposes, biologically, it shouldn't be, but it's how you interpret that pain, etc. Who we go for care. Well, I actually do care about your treatment doctor in your big fancy hospital, but I also want to go to my doctor in the corner. I want to see what he thinks. He knows better, my culture in the Dominican Republic. I want to know what he thinks about this food, etc. Or by the way, maybe I don't even get care from these hospitals or this kind of medicine. I'll get other care. It is very important. It's important to ask these questions, to access care, to reduce some of the disparities that we see. In no way I'm actually putting in this in a negative way. I'm actually raising these issues because they can help as well reduce disparities, even if used. If you think that you got cancer because of some issue that happened in your previous life, then is there a way to actually deal with that? And by the way, these are cases that have happened to us, and there are ways. By talking to some person and dealing with these issues, etc., there are ways to manage this. How we evaluate the care, and this is, if anyone wants to be a doctor, this is the one that actually you should know. Well, I went to the doctor, I went to the emergency room, I had lower back pain, they didn't even take an x-ray. This place sucks, I'm going to leave. This is how we evaluate care. If you don't do what I think actually you should be doing to treat me, most probably I will not like you and probably give you a bad review, but most probably, and most importantly, I will not follow your treatment. Well, put warm compresses and some patches there. Well, that doesn't make any difference. I want my MRI or something. If we don't explain those things, if we don't discuss these issues, can become a problem, and then have a different consequence in the outcomes of that, the health outcomes of that population. This is, in a nutshell, a lot of information on immigrant health and why some of those disparities exist. In no way is the whole story. We haven't talked about socioeconomic issues, education issues, health literacy issues. All those are actually very important as well. These are what I think, at least I see the most often, and what I think are those that can be best addressed by us, by people that care about these differences, that actually think are important. They can actually be managed to reduce the disparities. There's a lot of work to do, and I think as some of these topics, even if some of these topics sound very easy, they're not. They're very difficult, and I think the way to notice that is by that percentage of people, young people dying from cancer that were born abroad versus born in the United States. That difference should not exist, and these issues still exist. So a lot of work to do, and I encourage you to do it too. Any questions? Yes, please.
I don't know if this is a whole other topic, but what kind of opportunities are there to help reduce this disparity? What does your office do, and what can people that are maybe employees of the hospital but not in your office?
Yeah. So the first thought was also to put some of that information in this 1 hour. It's a lot of information, and we can spend another 2-3 hours just talking about that. But I would say that there is a lot. But think about it in levels as well too. So any of the areas that I discussed today have different solutions. Some of them we don't know them, and we don't know what the best solution is. But some of them do. The levels, policy levels. Keeping ACA or making it better, improving ACA, accessing care for undocumented immigrants, all those things are, participating in the policy and politics, etc. That's one of them. In terms of health and health policy, understanding the consequences of some of these issues and why they matter and what can we do, not just in a hospital or a clinical setting, but in the community. Most of my work, for example, is with community partners, working in the community, providing health or health information or dealing with these barriers at the community level, completely outside the care. So how do you do that? And there are multiple ways to do it. There's so many institutions doing that work, and our group is one of them. We do a lot of work in that sense. Language. Dealing with some of the issues that you're going to hear in the next month about using an interpreter, a trained interpreter versus your kid that is 9 years of age and speaks, your language. That makes a difference. A trained interpreter versus not trained interpreter. Understanding these issues are important. They actually have consequences in the outcomes of these populations. So I think even as a first step, like just backtracking a little bit, is that being aware of these issues is the first step. And there's so much that can be done at the academic level, with institutions like clinical level, but also in public health and in tons of other places. There are a lot of areas, and immigrants are the immigrant population, as I was showing you before. It's increasing, but it's mostly increasing also in places that are not used to immigrants. So very large populations in Georgia, for example. Georgia was not actually, it's not New York City, it's not California, or New York or California. They don't have the safety net that we have. They might not be used to the languages, etc. Translated some of those issues to those. I mean, there's so much to do and to continue to do. Yeah, that would be one way to answer. I mean, more specifics, I'm happy to discuss them afterwards, but there's a lot to do, a lot. And just by even just acknowledging this and educating the population about these issues, and we do a lot of navigation and community education, etc., just raising awareness, being aware of the different programs that exist. We have solutions, and sometimes it's not just about creating a new solution, but disseminating that solution. Another way to fix it. I know we're very late, so sorry about that. Any other questions? Because I know we're done by time. I'll stay here if anyone has any more questions too. Thank you so much.
Thank you so much for an incredible talk. Thank you. I just wanted to say a couple of things. Dr. Aragonis already plugged our next talk, which will be on language barriers to healthcare. Dr. Diamond is a terrific speaker. As Dr. Aragonis was talking, and we had discussed before, maybe we're going to have a session on food insecurity, maybe something on health problems that impact on refugee populations, something else on the Affordable Care Act. Based on your question, maybe it might be nice to have different representatives from the Immigrant Health Group talk about opportunities for students to get involved and volunteers to get involved in some of the things we're doing here. So I think that's a great idea. We're going to send you a survey, and we'd love to get your feedback and your input if you have suggestions on other talks. Please let your friends know. We can seat over 300 people in this room, and we can get more pizza if necessary. So please share the information with your friends because it's a wonderful opportunity. We want to share our expertise with you, and we want you guys to meet each other and for us all to create a learning community. So on that note, I say thank you and see you next time.
Thank you so much.
Thank you. It was really fantastic.
Thank you. Thank you.